Good evening, everyone. Can you hear me okay? Excellent. Okay, brilliant. So just to remind everyone, the autumn edition of the Power Course is now open for sale. Go onto the radiologymasters.com website if you want to join, and there you go here on this website here, www.radiologymasters.com. This is brought in combination with Hexarad, and Hexarad are making this uh, session free for you guys, and it's also reducing the cost of the Power Course should you wish to participate. Okay, let's get straight on to this then. We've got a patient who has got an incidental finding of a mass lesion projected over the right midzone. You can see the right heart border, and you can see the blood vessels coursing through the lesion. So the blood vessels are either in front of or behind the lesion, but because I can see the right heart border, that tells me that the lesion cannot be anterior. And because I can see the blood vessels, it means it cannot be in the middle mediastinum, therefore it's in the posterior mediastinum. And if it's in the posterior mediastinum, it must therefore be a schwannoma because it's solitary. So even though I don't have any sophisticated MR or CT, I can work out just by a process of elimination that this must be a schwannoma. The lateral film confirms that it's in a posterior position, and the CT scan also confirms it's in a posterior position. Now, if you were in any doubt that this was a mediastinal lesion, you can see the obtuse angle that the lesion makes with the chest wall. So an acute angle would be like this, and the obtuse angle is like this. So therefore, it's arising from a non-pulmonary structure, and in this case, it's arising from the posterior mediastinum. When we do the coronal CT, you can see that it is adjacent to the spine, and it's therefore likely to be either an intercostal schwannoma or a schwannoma arising from the intervertebral foramen. I think I may have showed you the next case last Monday, but for those of you who missed it, this is a really important radiological sign. So this patient has got volume loss in the right hemithorax. They've also got obscuration of the medial part of the diaphragm, which is here. And I can't see the interlobar artery because the interlobar artery has been pulled medially because the patient's got a right lower lobe collapse. And if you were in any doubt about that on the X-ray, doing the CT scan confirms everything, but we can just see that there is a bump just here, and there's the collapsed right lower lobe, and that bump indicates that it's probably due to a neoplasm. Okay, so when we do the CT scan, you can see that bump is here, and this is a malignant tumor causing a right lower lobe collapse. We've got hyperexpansion of the remaining right upper and middle lobe, and the CT also shows a pericardial effusion, which in the presence of a malignancy may well be due to a malignant pericardial effusion. So you can tell all of this just simply by analysing the film and working things out logistically. Okay, what's wrong with that patient's abdomen? Yeah, very good. Splenomegaly. So the bowel gas is pushed to the right and inferiorly. And in fact, this is the spleen here. Okay, so that's the spleen. Now, in the UK, there are 3 causes of splenomegaly that you need to come out with in the exam. chronic myeloid leukemia, lymphoma, and portal hypertension. But massive splenomegaly, it's more likely to be either CML, chronic myeloid leukemia, or myelofibrosis. And if you were in the tropical regions, you would think about Kala-Azar and malaria. But this is likely to be myelofibrosis. And if it's myelofibrosis, look at the bones and tell the examiner you're looking for evidence of bony sclerosis. You don't always see it, but this is still likely to be myelofibrosis. Okay, we've got this patient here who's got some ill-defined pneumonia, almost looks like a nodule, and then we've got lymphadenopathy here. What would be your most likely diagnosis? TB, you've got it. Yeah, primary pulmonary TB. Now, primary TB is more likely to be associated with mediastinal lymphadenopathy, whereas post-primary TB, you're more likely to get no lymphadenopathy, but you get a cavitary pneumonia. But the pneumonia in primary pulmonary TB is not cavitary, and you've got this associated lymphadenopathy. The other features of primary pulmonary TB would be pleural effusion, lymphadenopathy, and consolidation. Okay, so primary pulmonary TB looks completely different from secondary TB. Okay, now somebody's asked, why is this not a hilar lung mass? Well, it could be, but then it doesn't really explain this shadow here. And obviously, you would go clinically. So the patient would have an indolent cough. And although there is a bit of an overlap between carcinoma and TB in terms of symptomatology, you can probably work it out by doing a CT scan. And here's the CT. There's the lymphadenopathy. And here is the endobronchial nodular consolidation, very typical of primary pulmonary TB. Okay, what's the diagnosis here? CT scan of a patient who's got a lump in the proximal femur. Can primary TB present in adult life? Absolutely, definitely, especially in those patients who've not been immunized with BCG. Yeah, this is an osteochondroma. Looks a bit like a cauliflower, and it's a bony exostosis that arises, in this particular case, from the anterior cortex of the proximal left femur. And what you can't see on CT particularly well is the cartilage cap, and you may need to do an MRI scan to have a look at that. But before you do an MRI scan, look at previous films, because the previous film would be really useful in determining how it's changed from one film to another. Okay, so looking at previous films is really useful. And obviously, you also need to check the patient's symptoms. So if the patient's got increasing pain, that can sometimes be a marker of malignant change. But we really need to do an MRI scan in this situation. And the MRI shows the cartilage cap. Does anyone know how thick the cartilage cap needs to be before you start worrying? So here's the cartilage cap here. This high signal on the fat suppression sequence. Yeah, about 2.5 centimeters. But look at previous films because it's really, really useful. Okay. And the malignant change, of course, in an osteochondroma is a chondrosarcoma. Okay, what is going on in this patient? Do you think there's volume loss in both hemithoraces? Yes, somebody's answered yes correctly. So this tenting of the diaphragm is at the insertion of the inferior pulmonary ligament. So something in the chest, in the lungs, is pulling the diaphragm up, and that process is fibrosis. The fibrosis is leading to a mass-like area bilaterally, and we've got very coarse linear fibrotic strands. Now, in order to call it progressive massive fibrosis, you need to see it progressing. So Otherwise, it's just massive fibrosis on its own. So progressive massive fibrosis, you really need to see previous films. However, you can get a little bit of license when you've had a bit more experience. And I am confident in saying that this is PMF, or progressive massive fibrosis. The CT scan also confirms this mass-like area of fibrotic change with volume loss. There's septal thickening, subpleural nodular shadowing, bronchovascular beading, and most importantly, there's an bronchogram in the progressive massive fibrosis, which tells me that it must have started centrally. And if it starts centrally and works its way outwards, it must be PMF of sarcoidosis. Whereas PMF of silicosis starts peripherally and works its way centrally. But you're more likely to see sarcoidosis in the exam because it's much more common. But also, the silicosis is less likely to give you an air bronchogram. And silicosis is not very common these days because, of course, coal mining isn't very common. Okay, MRI scan. What's the diagnosis here? Yeah, the diagnosis on the last case was sarcoid. Yeah, bone within a bone, osteopetrosis. So this patient has got this bone within a bone appearance. You may not be used to seeing it on MRI. You're more used to seeing it on a plain film. But this is a definite case of osteopetrosis. Bone within a bone. Characteristic. There's nothing else really that gives you that appearance. Okay, this patient has got back pain. Tell me more. If you look at L1, there's T12. There's L1, L2, L3. Can you see the pedicles on either side? It's missing on the left-hand side. So we've got a missing pedicle just there. And that missing pedicle means that we've got a malignant destruction of that pedicle. So when you see that missing pedicle on the frontal projection, that almost always indicates that you've got a malignant process in that region. Okay, so obviously you need to do CT and an MRI scan for further evaluation, but you can pick up the diagnosis on the plain film. Yeah, somebody's called it the winking owl sign, and that's probably a very good description. So the owl's nose is here, beak, the beak is here, there's the eye, and we've got the beak here, the eye, and then there's no eye, so there's a winking owl sign. Very difficult to see it on the lateral film, but can you see this lytic process going on in the vertebra just there? So I'll just zoom that up for you. That lytic process just here in that vertebra, which is marching back to involve the pedicle. Okay, what's the diagnosis here? It's filling in peripherally with this nodular enhancement in the liver. Yeah, it's a giant hemangioma. It's virtually pathognomonic, okay? So it's a giant hemangioma, and this means that you get this nodular enhancement. You need to do an MRI scan because you need to look for evidence of sclerosis within the hemangioma. That's heterogeneity after contrast, and the sclerosis can sometimes be a marker for pre-malignancy. So It is definitely worth doing an MRI scan to just confirm that. And so this patient had an MRI scan, and we've got peripheral nodular enhancement around the lesion. Delayed enhancement scans on CT and MRI. Okay, spot diagnosis. What's the diagnosis here? Yeah, we've got Paget's disease of the right proximal femur. So we've got trabecular thickening, trabecular coarsening, cortical thickening. And when you look at the bone scan that corresponds to this, we've got contiguous increased tracer uptake involving the proximal femur, which goes into the diaphysis. So it's all contiguous and very typical of Paget's disease. Diagnosis here, painful knee. It's not a GCT actually. This was a metastatic adenocarcinoma. Okay, but the differential is a GCT. So saying it's GCT, although it's the wrong answer, it doesn't matter so much because you're going to go on to further investigations, which is going to then lead you to getting the correct answer. The key here is to just spot the abnormality. We've got cortical destruction, so it's malignant, and it's either a metastasis or a giant cell tumor, GCT. And in fact, this was an adenocarcinoma metastasis. Note also the patient's got varicose veins, just here. Okay, this patient has presented with weight loss and a cough. What do you think? Left upper zone nodule, no, that's okay actually. It's a bit of vascular calcification of the subclavian artery. SK has got it right. We need full exposure. This patient's hand is obscuring some of the chest x-ray. So what we need to do is we need to ask the radiographer to repeat the x-ray. And if we do that, guess what happens? We see a right lower zone carcinoma of the bronchus. So moving the arm reveals the carcinoma. Okay, so don't ever accept substandard films. Now, it may be that the patient isn't very well or that there's been some sort of technical issue, but always ask the radiographer to repeat the film so that you don't miss something like this. Okay, that might be the discussion that you have in the exam with the examiner. Okay, so always go for the highest quality x-ray you can get so you can get the right diagnosis. Okay, what's going on here? Got a lytic lesion which has been prophylactically pinned with an intramedullary nail. So what do you think? So it looks like an aggressive lesion. It's been prophylactically pinned, which is kind of circumstantial evidence that this is a malignant lesion, but it's not very hot on the bone scan. And in fact, it's not hot at all, it's cold. The increased tracer activity here is because of the intramedullary nail. Okay, so the diagnosis here is multiple myeloma. The fact that it's cold on the bone scan means that this is likely to be multiple myeloma. So you can give the clinician a specific diagnosis. How do you describe that femoral head and femoral neck compared to the other side? Yeah, it's remodeled and flattened. AVN, yeah, absolutely. And this is AVN from Perthes disease. So it's old healed Perthes disease of the hip. So when you see that, you know that the patient has had Perthes disease. And in fact, when you interrogate the patient, they will say, "Yeah, I had problems as a child. I had pins put in, etc., etc." So this is Perthes disease. Okay, this patient presents with a stroke. I think this is a really, really difficult film. Any thoughts? Left ventricular aneurysm. Well done. Just here. Really difficult to see. Much easier to see on CT. And there's the calcification around this left ventricular aneurysm, which you can just see here. And the reason why the patient's had a stroke is that the left ventricular aneurysm uh, is a potent site for the formation of thrombus. And so the thrombus gets flicked off during some sort of arrhythmia, and that thrombus then goes into the cerebral circulation, giving a cerebral infarct. Okay, abdo pain and weight loss. Excellent, well done. So, although this is an abdo film, always look at the lung bases, and we've got a nodule here, a nodule here, and I think that's a probably a renal calculus. And when you do the chest X-ray, you can see nodule, nodule, nodule. And these are pulmonary metastases from a malignancy. Okay, weight loss. What's going on here? Not TB. Yeah, we've got lymphangitis, multiple metastases. There's the normal breast shadow on the left-hand side, and the breast shadow on the right-hand side is deformed. Presumably, the patient has got a fungating breast cancer, or alternatively, they've had a partial mastectomy on the right-hand side. But the indication that this patient has got malignancy of the breast is evident by the asymmetry. And so this is breast carcinoma, pleural effusion, multiple metastases, and evidence of either a mastectomy or fungating lung cancer. Sorry, fungating breast cancer. My mistake. Okay, what is going on here? This is a trauma case. Yeah, so we've got a lunate dislocation. So the lunate is dislocated. So the lunate should really be this shape, and it's flicked over that way. And the capitate is in the uh, almost in the right position. It moves back a little bit, but this is a lunate dislocation because of the position of the lunate with respect to the capitate and the radial styloid. And also, we've got a triquetral fracture, which on this particular example is not seen on the lateral view, It's only seen on the DP view. Okay, what have we got here? I've turned it the other way around. So I did a lung biopsy on this 82-year-old gentleman. And what was I doing the lung biopsy for? Most likely carcinoma. Okay. And the surrounding lymphangitis in the lung, you can see the interlobular septal thickening. And on the left-hand side, we've got central lobular emphysema. That comes as no surprise because this patient is a smoker, so they are entitled to have emphysema, and the lung cancer is associated with the interlobular septal thickening that you see with lymphangitis carcinomatosa. Okay, I'm very grateful to Dr. Ashley Jennifer from Chesterfield for sending me this case. What is wrong with this patient? That's the thymus. Sometimes looks very alarming, but that's actually normal. The thymus tends to mold to surrounding structures. If you've never seen a thymus like that before, take it in because it's a bit alarming, but actually that is benign. Absent clavicles, well done. So there's no clavicle on the right and no clavicle on the left. So this patient has got cleidocranial dysostosis, or CCD, and the other features of this condition are, of course, multiple Wormian bones and a persistent anterior fontanelle. And when the child develops many teeth, there'll be supernumerary. So supernumerary teeth, persistent anterior fontanelle, multiple Wormian bones. What sort of esophagus would you call that? Yeah, it's a feline esophagus. And the feline esophagus is esophageal inflammation from eosinophilic esophagitis. And the reason why they call it feline is that cats have this kind of mucosal pattern. It's transverse rings, whereas the normal mucosal pattern is, of course, longitudinal. So this is a feline esophagus. So I'll give credit to the Radiopedia for this particular slide. It's not one of mine, and it was given by Dr. Evan Stein, and you can find it in feline esophagus in Radiopedia. But it's fairly typical of eosinophilic esophagitis. The more I practice, the luckier I get. Always remember that slide, okay? If you see things again and again and again, if you practice things again and again and again, you actually become quite good at them. You don't become skilled overnight. You have to put some effort in. And seeing things again and again and again is the right way to become an expert, okay? So always practice. Gary Player, at a tournament, chipped out of the bunker, landed 2 inches from the pin, and somebody said that was lucky, and he turned around to the spectator and said, the more I practice, the luckier I get. And never a truer word said. Okay, so we've got this patient here, young lady, 25 years of age, weight loss. She's got a mediastinal mass lesion here, a mediastinal mass lesion here. It's obscuring the aortic knuckle, so it must be middle. This is fading before it gets the clavicle, so it must be anterior. And so if you've got an anterior and a middle mediastinal mass, it's more likely to be a lymphoma than anything else. And if you look to the side, she's got swelling of her right axilla. compared to the left, lymph nodes, and she's got lymph nodes up here as well, perhaps not well seen. So she's got lymphadenopathy in the supraclavicular fossa, the right axilla, anterior and middle mediastinum. And what is my confidence level that this is lymphoma on a scale of 0 to 10? Yeah, no, it can never really be 10, but it's a high 9 because I can't think of anything else that would cause those radiological appearances. So one of the other features that you have to convey in the exam and in real life is to have enough confidence to make whoever's reading the report confident in you. So that's the thing that you can't learn in a textbook. You just have to practice and practice, presenting to your peers and to your consultants in front of an audience, maybe, so that you get it right in the exam. But also, it has significant implications for when you do the exam. The examiner has to be confident that you know what you're doing. That's very important. Okay, this is another case of lymphoma. This time, the lymphoma is involving the small bowel. We've got bowel loop separation. We've got lots and lots of intraluminal filling defects. Now, you have to make sure that that patient hasn't eaten a diet of baked beans or sprouts or something that's not very digestible, because they can produce filling defects. So the whole preparation for a small bowel meal is to exclude those kind of foods and to starve the patient before the examination. And then you're left with multiple nodular lesions, and you've got these strictures, and this is all turns out to be a lymphoma, and this was a MALT lymphoma. Okay, diagnosis here. Yeah, so we've got Ollier's disease, so multiple enchondromas, and we've got multiple phleboliths. So this converts the Ollier's into a patient with Maffucci syndrome. And Maffucci syndrome is of interest because it's more likely to result in malignant change. So the fact that we've got phleboliths in association with enchondromas means that we're likely to be dealing with Maffucci syndrome, which obviously has a higher incidence of chondrosarcoma. This is the same patient, by the way, and there's no hint of any phleboliths on this particular film, but you can see that the enchondromas are existing around the costochondral junctions. Okay, so it's quite a rare condition, but when you see it, you instantly know what it is, because there's nothing else that looks like this. Okay, so it's Maffucci syndrome, and the pre-malignant aspect of this condition is obviously very important to pick up, and these patients get monitored. Small bowel meal diagnosis. Yeah, so while you're looking at this, somebody's correctly pointed out this patient's got Madelung deformity, which is part of Ollier's disease or Maffucci syndrome. Well done. And these are enchondromas. Yeah, this is malrotation. So the DJ flexure should go like that. And the DJ flexure should be about here. And it's at the same level as the pylorus. Okay. But the DJ flexure is somewhere down here. Okay. So there's malrotation. And this is very important to pick up because, of course, these patients can present with bowel obstruction, usually when they are babies, but sometimes they can present later on in life. So it's important to understand the pathophysiology of malrotation. Okay, hip pain. It's not polio. Yeah, there's endosseal scalloping. So if you look at the cortex here, it's nice and smooth. The cortex here is nice and smooth, and then we just lose it. So there is loss of the cortex just here. And that's because we've got a permeative bony lesion. And if we look at it to the other side, there's a nice cortical outline here and a nice cortical outline here. And so this is a definite malignant bony lesion, likely to be secondary to a carcinoma from breast, bronchus, thyroid, or kidney. And they're the first diagnoses that you need to come out with in the exam. Clearly, myeloma can do the same, but it tends to give you scalloping. So a scalloping would be like this, where you've still got a bit of cortex, and it will scallop on both sides. Okay, so that's what scalloping looks like. But in this case, the cortex has been destroyed. And that destruction of the cortex is likely then to be due to a malignancy secondary to carcinoma from breast, bronchus, thyroid, or kidney. Okay, sclerotic rib, patient's got chest pain. Any thoughts? Yeah, so the patient has got sclerotic bony metastasis from breast cancer. So there's the breast on the left-hand side, there's a mastectomy on the right-hand side, and we've got sclerotic rib posteriorly, which has obviously caused chest pain in this patient. Okay, what's going on here? Yeah, osteoporosis circumscripta. So we've got well demarcated bone here, well demarcated bone here. And the reason being is that we've got two bits of bone which are osteoporotic. One bone is osteoporotic, and both bones are normal. So that's why you get this appearance that you can see. Probably better shown on the next one. So we've got almost like a cotton wool appearance of the bone. This implies that we've got one side is osteoporotic, and this implies that two sides are osteoporotic. Okay, and this is Paget's disease. Another example, cotton wool appearance, calvarial thickening. Okay, and we've got this rather well-defined lucent area, which is osteoporosis circumscripta. And it ties in very nicely with the bone scan, which shows this increased tracer activity, which matches the osteoporosis circumscripta. And because this is osteoporosis circumscripta, you need to look for evidence of Paget's elsewhere, and you can actually see it in the finger, just here, and in the sacrum. So looking at the bone scan, you can see evidence of Paget's elsewhere. there's another example of Paget's on a bone scan, where we've got the side view of the osteoporosis circumscriptor. While we're on the subject of nuclear medicine, what is that scan? Yeah, Meckel's scan, and the Meckel's diverticulum must contain ectopic gastric mucosa, which enhances or becomes radioactive at the same time as the gastric mucosa. And that just means that the Meckel's diverticulum contains ectopic gastric mucosa. And it's a technetium 99 metastable M, 99M pertechnetate scan, which gets taken up by the thyroid and by gastric mucosa. Okay. Emergency thoracotomy for a patient who had head and neck cancer. So they did an emergency tracheostomy, which resulted in surgical emphysema. There's the tracheostomy here, surgical emphysema here, intercostal drain went in. And about 4 days later, the patient became very febrile, and that fever was a bit concerning. So they did another chest x-ray. And what can you see on that chest x-ray? Yes, we've got a widened superior mediastinum. Can you see a fluid level in that mediastinum? So we've got a fluid level here, widened mediastinum because we've got an abscess. And so what's happened is that during the emergency tracheostomy, an emergency tracheostomy is going to be less sterile than a planned tracheostomy. So the patient has somehow developed an infection, which has caused a mediastinitis, which has caused a mediastinal abscess, which you can see here. So we've got a mediastinal abscess, fluid level, and I drained that using a pigtail catheter, and I used a posterior approach. The patient wasn't fit for surgery, so I drained it percutaneously. It was a bit hairy, I have to admit, but anyway, it was a successful outcome. Okay, what is going on here? Not lymphoma. If you saw that in the chest, what would you call it? Would you call it a mesothelioma of the pleura? Yes, you would. Therefore, it's a mesothelioma of the peritoneum. So the peritoneum and the pleura are very similar in their anatomical macroscopic structure. And therefore, there is a pleuroperitoneal communication through the diaphragm. And if you get exposure to asbestos, it can cause either peritoneal or pleural mesothelioma. Peritoneal mesothelioma is much less common, but it looks exactly like this. Okay. And you would want to ask the examiner, are there any features in the history to suggest asbestos exposure? So patients who work in the shipyard industry, lagging boilers, etc., etc. So that's mesothelioma of the peritoneum. This patient has got sclerotic bones and a big spleen. Any thoughts? Just on that last one, somebody's asked, can we call it peritoneal carcinomatosis? You could do, but this is more in keeping with mesothelioma. Yeah, this case is myelofibrosis because we've got a big spleen, massive spleen, and dense bones. This man is febrile and presents with being unwell, sweating, fever. Any thoughts? Yeah, miliary TB. Yeah, miliary TB, or somebody has put military TB, and that's because the spell checker on an Apple Mac will convert miliary into military. So Zishan and Zainab, I think, being a detective, you are using an Apple Mac. Am I correct? Correct. And yeah, there you go. So radiologists, yeah. So Zainab and Zishan, they've got an Apple Mac because when you put in miliary, it types military. And then after treatment, the chest x-ray is completely normal. Okay. Another case from Dr. Ashley Jennifer, for whom I am very grateful. This is a young patient, mediastinal shift to the right, paucity of blood vessels on the left compared to the right, volume expansion. Yeah, congenital lobar emphysema. Congenital lobar emphysema. Neonate, double bubble, ECG lead, nasogastric tube. Excuse me. Yeah, duodenal atresia. And this is a feature of Down syndrome. Excuse me. Excuse me. Sorry about that. Oh, I do apologise. Um, yeah, Down syndrome patients can get double bubble, duodenal atresia, infants of diabetic mothers. And if anyone asks you what this is, that is the umbilical stump. Okay. And this NG tube, that's the ECG leads. Double right heart border. So there's the right atrium. There's the left atrium. Mitral valve replacement. This is coronary artery bypass graft, cardiomegaly. So the patient's got mixed mitral valve disease, most likely. Now, mitral stenosis on its own doesn't give you cardiomegaly. In order to get cardiomegaly, you've got to have incompetence as well as stenosis. So the very fact that it's an enlarged heart means that you've almost certainly got mixed mitral valve stenosis and incompetence. Here's another case where we've got splaying of the carina, double right heart border. There's the left atrium. There's the right atrium. There's the left atrium. There's a pleural effusion. We've got upper lobe blood diversion, splaying of the carina, straightening of that left heart border, so-called mitralization of the left heart border. This patient has got mixed mitral valve disease. Okay, what have we got here? Yeah, multiple sclerosis, Dawson's fingers. So we've got increased signal involving the areas of the brain perpendicular to the corpus callosum. And you can see that on the enhanced view, we've got, I think we're at the wrong level here, but during the enhancement, these lesions did actually enhance. Okay. So I think I've put the wrong slide in, but they did enhance. So that indicates active demyelination, multiple sclerosis. Somebody has put their hand up. I can't remember who that was. Somebody wanted to ask a question. Why is the diffuse meningeal enhancement? There isn't actually. It's just contrast. It's likely to be in the venous sinus. So there's the torcular, and this is the superior sagittal sinus. It's not meningeal enhancement. What does mixed mitral valve disease mean? It means you've got a combination of stenosis and incompetence of the mitral valve. Okay, what's the diagnosis here? Yeah, medullary sponge kidney. So medullary sponge kidney gives you the calcification, which looks like a bunch of grapes. Okay. And medullary sponge kidney is the only cause of nephrocalcinosis that doesn't cause shrinkage of your kidneys. So whenever you see that, think about medullary sponge kidney. And okay, we don't do IVUs anymore, but if you ever get a CT urogram reconstructed or an IVU, always look at the control film, and the control film will then show you that this thing here is a stone in the renal pelvis, which can be associated with medullary sponge kidney. Okay, tell me what the exact diagnosis is here. Oops, sorry. I'll do that one again. What's the exact diagnosis here? Well, this is on the right-hand side, and this is the right-hand side. So it's actually a cold defect. So what's the diagnosis? Plasmacytoma or myeloma, which are effectively the same thing. Plasmacytoma is a solitary myeloma, basically, but it's never solitary. There's always more than one lesion. So this is a myeloma. I can see the aortic knuckle separate from this mass lesion, and it's either in the anterior or posterior mediastinum. The fact that I can see the aortic knuckle means it's not in the middle mediastinum, and in fact, this was in the posterior mediastinum, whose epicenter is up against the intervertebral foramen. So this was a schwannoma. So a posterior mediastinal schwannoma. Another example of the hilum overlay sign. We can see the blood vessels coursing through this structure. Therefore, it's not a middle mediastinal mass lesion. I can see the right heart border here. Therefore, it's not an anterior mediastinal mass lesion. Therefore, it can only be posterior. And that's what it was, confirmed on the lateral view. Rib notching. Okay, so rib notching here, 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 here. So what's the cause of the rib notching here? Coarctation could be, but before you say coarctation, always look at the periphery of the film. So I'm going to do this in a different color. Here, 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 and here, and here. So we've got neurofibromas or schwannomas, and the reason you can see them on the periphery of the film is that we're seeing the interface with the lung in profile. Whereas the rib notching, we don't see the neurofibroma because it's en face. but you see the consequence of that neurofibroma expressed as scalloping or erosion of the inferior rib. Don't forget, the rib has got the vein, the artery, and the nerve underneath it. And so the vein, the artery, and the nerve, any one of those three could be responsible for the rib notching. It's almost always due to coarctation, and that's what everyone says. But do look at the periphery of the film and make sure that you're not dealing with schwannomas or neurofibromata. Yeah, and that was the case in this patient. Okay, what have we got here? Trauma. Yeah, so we've got a radial styloid fracture just here, and we've got a triangular shape of the lunate. And we've also got a bit of calcification in the TFC. So that triangular shape means that we've probably either got a lunate or a perilunate dislocation. And quite often, these injuries are accompanied by radial styloid fractures or scaphoid fractures. So doing a true lateral, we will see that the lunate actually should be here, and it's moved in a 90-degree direction. So it's a lunate dislocation with a radial styloid fracture. There's that guy again. The more I practice, the luckier I get. You all enjoying this, by the way? Sorry, I didn't ask you. All enjoying it? Or is it far too hot and you want me to stop? Okay, great. Have a look at this one. What do you think is the association between these gallstones and this structure here? Yeah. So we've got ulcerative colitis, ileostomy because the patient's had a panproctocolectomy, and they've got associated gallstones. That's it. And the other thing that you need to say in the exam and in real life is tell the examiner what's going on in the SI joints. These SI joints are completely normal, but you want to tell the examiner that there is association between this condition and enteropathic arthropathy. So very important to mention that. Okay, I'm done, guys. Please, please, please do sign up for the power course. You will love it. There's much more of the same, but it's going to be myself